We're going to go down the femur a little bit more here. There's going to be a lot of overlap. And the next talk by Dr. Kredek will be even farther down the femur. So this is actually a case from my fellowship, and a guy who was parked on a fence. I'm going to talk about subtrochanteric fractures, and you'll see I'm going to talk about what not to do, what the anatomy does to the proximal femur, and how it predisposes to varus and procurvatum, a mechanical cause of malreduction, intraop technical cause of malreduction, treatment options, and then tips for how to successfully reduce. So a couple of cases first of what not to do. This 89-year-old female, she fell from standing. She has this complex peri-subtrochanteric fracture. You can see that her bone is basically made out of paper. And if you look closely, you can see the vessels. She had a heart attack 6 months ago. So here what we're worried about is how we're going to reduce this thing, right? What are we going to use as far as implant? Where are we going to place the implant? And what are we going to do for post-op? Post-op for these patients is weight bearing is tolerated, right? Every single time. That's the goal. So this was actually what was done. Does anybody see a problem? Nobody sees a problem here? You don't see any problems? Okay, the problem here actually is on the lateral view. So if you look at the AP view here, actually her neck shaft angle is not too bad, but in the lateral view basically completely missed the neck, and the neck is flexed. This patient goes on to post-op day 4, basically fracture below the implant, and then she passed away actually 12 days later. So there's no follow-up on her other than that. So here, what not to do. Next one, 85-year-old lady. Again, she's a mother of 8 children and has, I think, 25 grandchildren or something. This is January 2006. She has this problematic, I would call this a subtroch, really. And you can see that there's also extension up into the greater trochanter. She gets fixed this way. This is an intraop image I was able to get from the other hospital that she was at. Anybody see a problem here? A little bit of varus, right? She's at about 14 degrees of varus relative to the contralateral side. And I see her 2 years later with a non-union and a fracture with an anterior angulation or procurvatum of the femur of about 10, 15 degrees, something like that. And at that time, there were no fancy implants, so we had to just take a contralateral distal femoral plate, turn it upside down, and do a valgus osteotomy. So this is examples of 2 cases of what not to do. Now we'll talk about all the issues. So Dr. Borelli spoke about the proximal femur and how the proximal femur gets pulled by the muscle forces, which is basically abduction, flexion, and external rotation. The mechanical axis of the femur actually is medial to the lesser trochanter, as you see in the yellow line that pulls down. Once you put implants in, you have compression on the medial side and traction on the lateral side. That's what the implant sees. And if you think about where you put your hardware, this would be a plate laterally and a nail intramedullary, and that would be the fixation there up into the femoral head. So the lever arm between the axis where the mechanical axis is and the plate is much farther than it is for the nail. And so a nail has an advantage for trochanteric fractures. And if you look at how the plate then gets held, the plate gets held by the screws distally. And so you're relying on the pull-out strength of those screws, whereas a nail is actually inside of a container, basically, holding it in place, so you don't have to worry about pull-out. So that's why the nail is really a gold standard for this type of injury. There are a bunch of studies looking at this and showed that cephalomandibular nails are axially stiff, they increase load to failure, and they increase cycles to failure, whereas plates essentially are more lateral positions, as I said, and they have greater bending forces that the plate sees, as well as decreased load to failure. And this is kind of what you see with the implants that have been used. This is actually a malunion. There was a subtroch fracture where the whole proximal fragment fell into varus, and then we're able to actually bring it up into valgus using a nail. Okay, so why do malreduction occur in varus and procurvatum, which is what you see here? Why do you get varus? You get varus because the fracture is not reduced before reaming, right? You're not holding the fracture reduced during reaming. You're not holding the reduction during nail insertion, and you're not holding the reduction while we proximally lock. So that means you need to make the reduction and hold the reduction throughout that whole process. Otherwise, you can lose your reduction. If you have a problem with the nail size, so you have to understand your implant as well. The nail size is really important proximally. So if you look at essentially this particular nail, it's a very large nail which abuts the lateral cortex and actually pushes that proximal fragment into varus. So the nail itself, the intermedullary canal can't hold the size of this nail. And the same thing happens on the medial side here, where essentially the nail abuts the medial side, and that causes the whole proximal fragment essentially to rotate around the nail and causes varus. You can also have ovalization of the entry hole. I'll show you what that means in a second. And then just not understanding the nail anatomy, because what happens is once you put the nail in, the nail will force the fracture to fit the nail, because the nail is a piece of metal. It's not going to move, and you have a fracture which will rotate around the nail. Okay, so why do you get anterior angulation or procurvatum? Inadequate imaging, I think, is one of the top reasons. Basically, you're not seeing proximally well enough to be able to see that it's actually kicked up. The other reason is exactly the same thing as varus. Essentially, you haven't reduced the fracture, you're not holding the fracture during reaming, during insertion nail, or during proximal locking. It has to be reduced during that whole time. The entry can be too anterior, and sometimes that happens because of imaging. And if the entry is too anterior, basically you kick up the proximal fragment and force it to be in procurvatum. And if you have too much traction, that pulls on the iliopsoas, causing it to flex. So trochanteric nailing of femoral nailing in this place, essentially the correct entry we would call trochiformis for most nails, which means that you're on the medial side of the greater trochanter. You can even medialize a tiny bit more to get valgus, because I think valgus is okay, whereas valgus is not okay. Varus is not okay. Too much medial gets you into valgus. This is a study by Ostrom, it's already been talked about previously. Essentially, that all these different nails have different proximal bends, and you just need to understand the anatomy of the nail. Proper insertion site, I think I would say that the money is basically just medial to the greater trochanter, and that's the view you should see when you're taking imaging of the proximal fragment and putting the nail down. Okay, let's talk about too lateral entry. When you're too far lateral, essentially what you see here is that this is the entry site for each one of these nails. These are 4 different nails, again from Ostrom study. And what you'll see here is that when the nail is large, you have buttress that is happening on the lateral side of the femur intermedullarily and on the medial side distally. And that causes this, the proximal femur to rotate. And you can see that in these 2 nails that have a larger proximal diameter of the nail. Whereas when you have a smaller diameter nail, what happens is that you're not in too much varus, but essentially you rotate until the medial side of the distal fragment, of the distal part of the proximal fragment, abuts the nail, and that's where you stop, where the varus will stop. Whereas in this particular nail, same thing happens, but you just get some translation. So those are all the reasons why the nail itself can be a problem. Of course, a clamp in that position will just hold it reduced, right? Okay, this is the setup, at least in my hospital. What I do is I put the patient in scissor position or in lateral decubitus position. Those are the 2 we use. This is the kind of lateral that you want to see, where the head, the neck, and the shaft are basically lined up, and that takes out the version from the proximal fragment and shows you exactly where the nail and the lag screw should be in line. I like to use extramedullary reduction tools, so using the HANA table, which is what I personally use. Basically, there's an attachment to that table that you can use like a crutch, which raises that distal fragment and brings the distal fragment toward the proximal fragment. That's a pretty simple way to do it. Instead of a crutch, you can use a crutch as well, but the crutch, the C-arm hits the crutch on the bottom, and that can cause a problem. Always make sure that you prep and drape more anteriorly in case you need to do a reduction. For instance, putting a ball spike pusher anteriorly, you want that prepped. That looks like that. So here's a 57-year-old obese male after pedestrian hit by a vehicle. He's got this complex subtrochanteric fracture with extension proximally. That's what the lateral looks like. The nice thing about this one is that if you look closely, you'll see that the lesser trochanter is off as well. So here's our setup. This is the old table, but that's our setup in the hospital. I like to put, again, that bump distally here to hold it, hold that distal fragment. And then, obviously, put the nail down. But here's what's really important. This is a lateral view showing that proximally the neck shaft and head are in line. We're on the medial part of the greater trochanter and put the hardware in the right position, and that's what the reduction looks like on him. I'll show you a little bit more complex cases. Short segment femur fracture. This is a patient who jumped 30 feet and wound up in our hospital with these fractures. Again, a subtrochanteric fracture. He also has a fracture that goes up into the femoral neck and a sacral fracture, which we're not going to talk about. In this particular case, all we care about here is that the neck, the head, the neck, and the shaft are in line, and we're using a cob through a small incision, as Dr. Borelli was talking about, to hold that proximal piece down. Here, the construct, we put the nail a tiny bit too low, and you see that the screws are a little bit low on the neck. But that's how it looks. And those are the incisions. And then another one, 67-year-old cyclist who likes to ride a bicycle. Yeah, that's me too. Unfortunately, this is what happened to him. He has this complex subtroch fracture. And here you can see as we get a lateral view, it's obvious that he's got flexion of the proximal fragment, and we need to do something about that. So we want to push that proximal fragment posterior and the distal fragment anterior to get this to line up, or just put a clamp on it. This is from the OTA resident lecture series, and you'll see that these are all the different ways that you can actually hold these fragments in good position. Right? There's many ways of doing this, and the most important thing here in my mind is no varus, no anterior angulation. So do what you need to do to open this thing, to open the fracture and get it reduced. So that's what it looks like after doing that. And I like to have a couple of images of the neck. I like to see the anterior of the neck and the posterior part of the neck by rotating the C-arm a little bit to get those two views. That's what you saw there. That's how it looks post op. So again, why do you get varus? Just to sum it up, because you're not holding the reduction while doing all the things you need to do to put the implants in. You're a little bit too, you get lateral abutment from the large size nail, so using a smaller nail head in some of these fractures makes it easier to do. You get medial distal cortical nail abutment, ovalization of the entry hole, and not knowing the proximal bend of the femur of the nail. Why do you get anterior angulation? Inadequate imaging. I think that's the #1 thing that I see, inadequate imaging. And then again, not holding the reduction while you're doing all the things you need to do in order to get the implant in. Too anterior entry hole and too much traction. So again, avoid varus or procurvatum. Anatomy has the predisposition to bring us into varus and procurvatum because of the muscle pull. And the mechanical axis is medial, as we said, and because of that, it causes high stresses on the implants and malreductions, and that's something you have to overcome during surgery. Intra-op technical causes of malreduction we talked about, which has to do with the nail and the reduction and holding of the reduction, and treatment options and gold standard. I think the gold standard here is obviously a nail and not a plate. So thank you so much.